Good afternoon, everyone. Welcome to this multi-jurisdictional CAC meeting. I am now going to turn the meeting over to Dr. Mann, who will start the presentation.
Good afternoon, everyone. My name is Patrick Mann. I am a contractor medical director at National Government Services. I wanted to start off by saying that this call is being recorded and transcribed. Please mute when not speaking and state your name before comments. And once again, good evening, everyone. We know your schedules are full, and so thank you very much for making time today for our evidentiary CAC meeting discussing implantation of anterior segment intraocular non-biodegradable drug-eluting system via internal approach. Our goal today is simple: hear the expertise from our esteemed subject matter experts and examine the evidence together. We value the breadth of perspectives across centers and practice settings. For today's discussion, please keep comments concise and evidence anchored. When possible, reference specific trials, registries, or guidelines. If you disagree, we greatly appreciate the discussion, so please briefly share the rationale and the data that informed your view. A few housekeeping notes. This session is recorded. Please avoid sharing any patient identifying information. The raise hand feature is available for the subject matter experts. This is not an open meeting. The only speakers on the recorded line will be the subject matter experts and the contract medical directors answering questions. When answering a question, please state your name for the record. For conflicts of interest, if anything has changed since your disclosure, please state it before your first comment. For timing, we will aim for about 10 minutes per question, of which there are 10. We may gently keep us on track, and please know it's not to cut ideas short, it's to make sure that we hear from everyone. Our objective today is to review and critically evaluate the literature on the implementation of anterior segment intraocular non-biodegradable drug-eluting system, what it demonstrates, and where uncertainties remain. Before we get started, I want to recognize the Medicare Administrative Contractors joining us today and thank them for contributing to the discussion. These contract MACs are National Government Services, CGS Administrators, Palmetto GBA, Noridian Healthcare Solutions, Wisconsin Physicians Service Insurance Corporation. And then our esteemed subject matter experts are as follows. We have Dr. Javed Saeed, retinal surgeon at Discover Vision Centers. He reports no conflicts of interest. We have Dr. Jeffrey Emmerich. He is a physician at Consulting Ophthalmologist PC. He reports no conflicts of interest. We have Dr. Nora Lee Cothran, consultative optometrist at the Eye Institute of West Florida. She reports consulting for glaucoma, including review of phase 2 and 3 clinical trial data and providing professional opinion on ideal and appropriate patient types. We have Dr. Julia Ann Rosedal, Associate Professor of Ophthalmology at Duke University School of Medicine. She reports no conflicts of interest. We have Dr. Steve Mansberger, Chief of Ophthalmology at Legacy Health. He reports no conflicts of interest. We have Dr. Vikas Chopra, Physician in Ophthalmology at UCLA Health. He reports no conflicts of interest. We have Dr. Daniel Liebman, staff ophthalmologist at Mass Eye and Ear. He reports having provided consulting services for AbbVie in the past and has no ongoing financial relationship with any relevant entity currently. We have Dr. George R. Wandling, Jr., who is an ophthalmologist with Twin Cities Consultants. He reports receipt of research funding from Alcon and Glaukos and is a consultant for Glaukos. And finally, last but not least, we have Dr. Nauman Imani, Chair of the Department of Ophthalmology at Henry Ford Health. He reports no conflicts of interest. And with that, we will go directly into the questions. So can you please move the slide forward? Actually, go back a couple. Let's get to the agenda. The way that the agenda will go is we will be going over 10 questions. attempting to get it in within 10 minutes per question. And then we will move to closing comments around 4:50 p.m. Eastern Standard Time. Thank you. And then let's move to our first set of, one more thing before we get started. This is the definitions we have for the quality of the evidence grades. It's based on the grade manual, GRAD manual. And so this is here for your reference. Okay, next slide. Okay, so the first question we would like to ask the group is, what is considered to be the standard treatment that would be considered effective for glaucoma management? In other words, what would be the optimal primary endpoint for studies investigating glaucoma treatments? And then the first part of the question would be, how is progression of glaucoma measured? Are the methods of measurement and data interpretation reproducible across practitioners? Are the measurements precise enough to allow to establish the degree to which a disease process is slowed? And we'll start there. I'll read off the remainder parts of the question as we go. But do we have any volunteers? Dr. Chopra, please go ahead.
Hi, I'm Vikas Chopra, and I have no financial disclosures. So the mainstay of treatment for glaucoma is essentially lowering intraocular pressure, and it's really the only proven intervention to slow down or prevent glaucoma progression. The American Academy of Ophthalmology Preferred Practice Guidelines recommend an individualized target intraocular pressure lowering, typically aiming for a reduction in pressure of at least 20 to 30% below baseline, with more aggressive lowering for advanced or rapidly progressing disease. Now, the challenge is that the optimal rate to determine progression would be visual field decline, but often that takes time to measure. So the practical guidelines are typically looking at intraocular pressure measurement lowering from baseline. And the standard for determining whether the treatment is effective in glaucoma management is the achievement and maintenance of that target pressure that can stabilize the optic nerve and stabilize the visual field over time with no evidence of disease progression with either structural or functional assessment. And a strong relationship does exist between pressure reduction, that's intraocular pressure reduction, and stabilization of glaucoma. So intraocular pressure is considered a valid clinical endpoint to evaluate the efficacy of glaucoma treatment. And finally, the ideal measure of success of any glaucoma therapy is prevention of further glaucomatous optic nerve damage and preservation of visual fields and quality of life. So treatment success for individual patients is difficult to define by an arbitrary IOP level, intraocular pressure level, because individuals can vary their susceptibility in their optic nerve to damage up from the pressure. Nonetheless, pressure reduction is the goal of all current glaucoma therapy, and really no other surrogate measure better reflects therapeutic success. Thank you.
Thank you very much. Would any of our other subject matter experts like to comment on this first part? Okay, then for the second part of the question is, does intraocular pressure reduction affect all patients the same? What is the % success rate of lowering intraocular pressure to slow disease progression? What would define success, which you've already in part defined? In what studies is the success rate demonstrated? And is there a way to determine which patients would or would not benefit from lowering intraocular pressure? Go ahead, Dr. Emmerich.
Yeah, hi. Just wanted to go back actually to part A there, the measurement of progression, if we could.
Please do.
Yeah, just briefly. So we all know glaucoma progressions measured by serial assessment of both structural and functional changes using OCT to measure the nerve fiber layer and ganglion cell inner plexiform layer, standard automated perimetry to detect visual field deterioration. And so we track structural progression by OCT, quantifying thinning of the RNFL and the GCIPL. And those changes often precede visual field loss. So OCT is a very sensitive tool for early detection and monitoring. And if you combine the RNFL and the macular GC-IPL measurements, that improves sensitivity for detecting progression compared to either one alone. And it's nice to integrate those for comprehensive monitoring. You can quantify rates of thinning over time. Faster thinning is associated with higher risk of field progression. And then for functional progression, we measure that with the standard automated perimetry, evaluating change in visual field sensitivity, and it's important to do serial fields. You can do trend analysis of the mean deviation or event-based criteria to detect statistically significant progression. If you do more frequent testing, a couple times a year at least, initially, you can have earlier detection of rapid progression. And of course, confirmatory testing is recommended by the American Academy of Ophthalmology Preferred Practice Panel before changing management, because sometimes you'll have a false positive change. So you want to show reproducibility. Clinical examination is, of course, still very important. Optic nerve head imaging by photography or drawing to document changes in cupping and the nerve thinning. And really, to assess all of these, it needs to be done on an individual basis based on disease severity, rate of progression, risk factors. And again, integration of all these measures really allow us to reliably assess for glaucoma progression. If the nerve field shows progression despite reaching a target IOP, then we try to lower the target further and intensify treatment. But if the disease remains stable, then we can consider the current therapy to be effective.
Great. Thank you for the very thorough overview. I have a couple of questions I will ask after Dr. Cothran gets a chance to speak. Go ahead, Dr. Cothran.
Hi, Norley Cothran. Additional disclosure of consulting and lecture fees for AbbVie. One thing I wanted to mention was we're mentioning fields. I think it's important to mention 24-2 and 10-2, both fields. We know that through our recent publications and understanding of within the genetics literature of recognizing that positioning of the field defects can differ from patients that start with higher levels of baseline IOP untreated versus patients start within the normative range, and the fact that the previous group of patients start with field defects that may initiate more peripherally, and then paracentrally and centrally, patients that have those normotensive type starting pressures can have defects that affect the central vision. And because of that, then another way that progression of glaucoma can be measured is with functional visual acuity in the patient's subjective reading of something like a Snellen chart in the office, because additional publications have shown that patients have damage within that central 10-2 often have impact to their ability to read the Snellen chart.
Great. Thank you. Very interesting. So there's a couple of things that came up here. One of the first things that I wanted to ask is, how does this relate to normal pressure glaucoma? So obviously elevated intraocular pressure, which correct me if I'm wrong, is above, I think 21 is the threshold, upper threshold generally, millimeters mercury. So how does this play into normal pressure glaucoma? Dr. Mansberger, please go ahead.
They basically are like
Talking what down?
they're talking
Sure.
the implantable down.
Who's who's speaking?
Not with.
I don't know who is speaking, first of all, and then I think Dr. Mansberger has the floor.
Oh, hi. This is Steve Mansberger from Portland, Oregon. No conflicts of interest. Yeah, so as far as the normal tension versus, for example, high tension glaucoma, the way that I explain this to patients is the normal tension glaucoma patients who have pressures maybe at 18 or 19 and continue to develop progression of their structure or of their function is they just have a more fragile optic nerve than perhaps some of our patients who might be called ocular hypertension, who have pressures in the mid-20s and never develop damage. So they just have a more fragile optic nerve. And the treatment is still the same, is that you need to lower their pressure. As Dr. Chopra talked about, somewhere between 30% of lowering is what you need to do, at least in some of these patients. And then you just follow them over time to see whether or not their disease stabilizes. If it doesn't, then you would advance therapy, as Dr. Emmerich had talked about before.
Thank you. Just to keep consideration of time, Dr. Imami, please go ahead.
I completely agree with what Dr. Mansberger said. I think it's also important to add if there are individual traits within the patient that may make you determine whether they may be at higher risk of that pressure having an effect. For example, what the corneal thickness is. And if corneal thicknesses are thicker than average, you may be overestimating their intraocular pressure, and therefore they may be a lower risk. Or if they have thinner corneas, you may be underestimating their intraocular pressure. So there are some intrinsic patient factors that can also be looked at when you're looking at intraocular pressure.
That's a great point. Thank you very much. So I will continue to write down questions as I have them. I will continue on the questions just to make sure that we get through them all, but if at the end we have extra time, I will come back to them. Just one other thing. Oh, and the offer extends to any of our contractor medical directors that want to jump in as well. I will hear one more comment from Dr. Wandling, and then we'll move on to question number 2. Go ahead, Dr. Wandling.
George Wandling. Previous conflict with research with Glaukos and previous consulting with Glaukos. Knitting point is, and these are screened for in many studies, is we check diurnal variation of the intraocular pressure, because you'll see patients with glaucoma that may fluctuate with even as much as 10 points in a day. And so maybe you're always catching them and they're 18, normal, and but in fact, they may be much higher. It's just something to always be cognizant of.
And when you say 10 points, do you mean 10 millimeters of mercury, or just clarify what you mean by 10 points? Okay, 10 millimeters.
10 millimeters, excuse me.
Yeah, no problem. Thank you. Okay, next slide, please. So question number 2, based on the pivotal studies, which are referenced as 4 through 7, do you consider the anterior segment intraocular non-biodegradable drug-eluting system an effective management for lowering intraocular pressure for patients with mild to moderate open-angle glaucoma? And then do you consider it to be effective management in ocular hypertension? Dr. Saeed, please.
So I mean, I think at least based on studies, there's pretty robust IOP lowering across studies. And since IOP is a marker sometimes for glaucoma progression, it seemed like it's an effective device. I think from our standpoint, we all know that travoprost, which is the medication that's being eluted, it's a prostaglandin analog, and we've been using those for years to lower IOP. I think this is just a novel way to get it into the eye. And so not a big surprise, there's pretty robust IOP lowering, and theoretically in the long run, that'll lead to slower progression of glaucoma.
And then for and then I'll get to Dr. Chopra in a sec. And then for ocular hypertension as well, so where would so you'd be using it for both?
Yeah, I mean, I think that's like a tougher thing to tease out, because if it's ocular hypertension, we don't really know for sure if they're gonna develop glaucoma. I think there's a thought if their pressures are high or quote unquote too high, they will. It lowers the eye pressure. Whether or not those patients would be at risk of glaucoma at baseline, I think it's a little bit hard to tease out for individual patients, but it certainly does a good job lowering pressure, which is what we're doing for ocular hypertension and what we're doing for glaucoma. That's how we treat both those diseases if we're going to treat them.
So would the surgery then be more indicated? Sorry, not the surgery. Well, the surgery for inserting the device be more for just the glaucoma, and the ocular hypertension would be more other methods, or would there be reasons to use it in ocular hypertension?
Yeah, I mean, I think if you have, for example, a patient who has had documented glaucoma in their other eye or a strong family history, and there's a high clinical suspicion that their ocular hypertension will progress to glaucoma, and maybe they're difficult to use other modalities like drops or poor compliance, then I think it's reasonable. But I'd sort of err on the side of, or it seems like a great treatment for glaucoma. Hard to know how many people are going to use it for ocular hypertension alone.
Great, thank you. So I saw Dr. Chopra is next, and then we'll go to Dr. Wandling. So go ahead, Dr. Chopra.
Thank you. So, this actually is a really interesting question, and I do think actually this drug-eluting system is quite effective in lowering intraocular pressure. But I wanted to go back to, we kind of skipped over a little bit of 1B, and you had wanted some evidence-based information, and this question kind of helps me address that, if you don't mind. So,
no, I don't mind at all.
For one thing, the ocular hypertension treatment study actually was it's a landmark clinical trial in ophthalmology, and really what it did demonstrate is intraocular pressure lowering of at least 20% reduces the risk of development of glaucoma by, cuts it in half, essentially. Now, as it was stated before, not everyone with ocular hypertension develops glaucoma, but the OATS study, which is the ocular hypertension treatment study, clearly demonstrated certain risk factors. Okay, so patients who have thin corneas, especially greater cup to disc ratio. So there are particular risk factors that you can look at, and you can decide those patients really are the highest risk of developing glaucoma. And now we have actually OATS 2, which is a 10-year study, and OATS 3, which is a 20-year study, showing that much greater risk of developing glaucoma with untreated ocular hypertension. So that's important. And then the second part is that if you take patients who are just beyond ocular hypertension, and there was a study called the Early Manifest Glaucoma Trial. So this is a study done in Scandinavia that looked at patients who had early open-angle glaucoma, and half the group was treated and half the group was not treated. And the treatment group, essentially had reduction in progression by about half again. And what it actually demonstrated is that even 25% pressure reduction still had some patients progressing, even though the rate was cut in half. So early treatment is incredibly effective in reducing the risk of developing glaucoma and managing intraocular pressure is the way to do it. The other thing is, one other thing that Dr. Imami and Dr. Mansberger talked about, the normal tension glaucoma, and I wanted to kind of give you information about that. So there was a study called the Collaborative Normal Tension Glaucoma Study. This is, again, a landmark study, started in the 80s. And at that time, the thought was that glaucoma is always related to higher eye pressures. That's kind of what I was learning. And so when I was in fellowship, we said, okay, is glaucoma actually, can it develop at pressures that are not high? So these were groups, two groups. One group was studied without treatment, and the other group was treated in patients who did not have intraocular pressures in the higher range above 21 on average and over 21 on a single visit. And it also confirmed that there was a threefold reduction in progression in the treated eyes compared to the untreated eyes. So at that time, the definition of glaucoma was changed. The higher pressure was no longer part of the definition of glaucoma. So glaucoma now is defined really as a progressive optic neuropathy that leads to, glaucomatous optic atrophy and visual field loss. So I wanted to kind of tie all that back in to your question. But I do think that having a sustained clinically meaningful pressure reduction that, a drug delivery system can provide with a relatively, safety profile does have value in our armamentarium, and really, I feel, in all actually stages of glaucoma. Thank you.
Well, I appreciate you bringing those things up. I did want to ask kind of a follow-up question to that, in that, is there any discussion or attempts to elucidate why lowering the intraocular pressure doesn't work for some patients? I know that the literature does say things that sometimes identifying pure glaucoma as opposed to other potential etiologies sometimes can be difficult in some cases, and that those may muddy the waters in some of these studies. But I just was wanting to get a follow-up on that as well, and then we'll go to Dr. Wandling.
Yeah, that's a great point. So that actually also addresses the 1B, which talks about does IOP reduction affect all patients the same? And reduction in pressure doesn't affect all patients the same in the same way. There are patients who have myopic retinal degeneration, tilted optic discs that have a lower baseline optic nerve health, as Dr. Mansberger alluded to. So in those patients, that they may be at high risk of progression, even if the pressures are lower. And actually, multiple studies have shown that in normal tension glaucoma patients do tend to have often intraocular pressures related to blood pressure, in that patients who have hypotension, systemic hypotension, are having ischemic, perhaps damage to the optic nerve. And so often these patients have this dip in their systemic blood pressure at night when the intraocular pressure is higher. And so that mismatch can lead to progression. And I think one other speaker had mentioned, how diurnal variation is so super important. And that's where if you can have a consistent delivery of drug over time, perhaps, we can make a better difference than having, giving intermittent drops to the eyes. But yeah, there are multiple factors in normal tension or low tension glaucoma, including systemic issues. These are patients who often have systemic low blood pressures, peripheral claudication, and history of migraine headaches. So there's a vasospastic phenomena that goes along with these patients. But again, intraocular pressure reduction does work in most cases.
Thank you. Dr. Wandling, and then we have Dr. Cothran.
I'm returning to question 2 again. So yes, I think most of us are going to say yes. We believe that these drug-eluting systems are an effective use for lowering the intraocular pressure. I think one of the things that people are going to get hung up on is mild to moderate versus ocular hypertension. I think if you lined up 100 patients that were labeled as mild ocular hypertension and mild open angle glaucoma and 100 that were ocular hypertension, you would get a huge breadth of opinions among glaucoma specialists of who's actually mild and who's an ocular hypertension, where is that line? It's not very well defined. And so that's more of a coding thing and less of a goals oriented, and it's very much opinion. And so
would that affect
just
trial
getting
results? I'm sorry, would that affect trial results, being able to extrapolate from trial to trial?
I think that each trial will have it defined as what they believe to be ocular POEG mild versus ocular hypertension, but even within trials that is variable. And so that what makes it a little bit difficult to say, would I not treat an ocular hypertension patient with drops or this drug delivery device? Because some people may say, well, that's actually mild because they have some OCT changes, where other people will say, well, it's not, I haven't seen OCT velocity change, right? And so you may say, well, this is where they were born versus this is how it's changed over the last 5 years. And so it's difficult to you can't project that. And that's, again, what the OATS trial is one of the things that shows is you can't project who is going to be the people that are going to have that velocity or that change over time. And so, again, to return to the effectiveness, yes, it's effective. Yes, it's useful because some people are going to be highly intolerant to drops, and so that's why these systems were developed.
Great, thank you. And then put a pin in this. I do want to talk a little bit more, if we have time later, about the OCT measurements and how these relate to the trials. But for now, we're going to stick to question 2 for one more person, Dr. Cothran, and then we'll move on to question number 3. Go ahead, Dr. Cothran.
Yes, thank you. This has to do with the question regarding patients that continue to progress with low and normal tension that are treated, and then they continue to have field progression or progression on their RNFL. Very similar to Dr. Chopra, what he mentioned. We have other extrinsic factors that are outside of IOP, so you can lower the eye pressure all the way down to potentially the point of episcleral venous pressure with topical therapy and take the stress off of the optic nerve from inside of the eye. But other conditions, systemic conditions like obstructive sleep apnea, actually impact the blood flow that goes into the actual optic nerve as it travels along across the chiasm and toward the back of the eye. And so I tell patients all the time, I can control everything inside of the eye, but there are other things out of my control that we have to be able to identify. So if a patient's progressing and they are controlled as low as we can go, then we may have something like OSA, or we now understand that when patients are sleeping, they may be experiencing pressure spikes at night that are not controlled by topical molecules, but that can be controlled in patients that have had tubes and trabs and incisional surgery. The second point had to do with the question number 1, the last question B, and it said, is aware to determine which patients would or would not benefit from lowering IOP. We now have a wide body of data within genome-wide assessment studies, association studies, that have been able to create these polygenic risk scores. And in a post-hoc analysis of the OATS data of that pivotal trial, we found that patients that were in the top 10% of polygenic risk scores, even those that had low risk factors, like they would have been considered low risk for conversion based on the original OATS data, when we look at the genetics, those patients actually have a much higher risk of progressing if they're in the higher 10% versus those in the lower 10%. So these types of studies are just making their way into commercial production, but it may be a way to determine which patients would benefit from treatment and which would not. Thank you.
Thank you very much. Okay, let's move to the next slide. So question number 3 is there evidence to guide selection of this device over other treatment options, which are going to be listed below? If there is no evidence, what factors would you consider in making this decision? So we have medication alone, we have the MIGS procedure, we have extraocular therapeutic options, which include wearable ocular surface devices, punctal plug systems, and subconjunctival injections. And then finally, other intraocular platforms such as bimatoprost sustained release. And remember, the question is there evidence to guide selection of this device over other treatment options? Dr. Imami, please go ahead.
So I think there's great evidence which shows that this device lowers intraocular pressure robustly, just like other therapeutic interventions that exist. The question is comparing head-to-head different forms of treatment, different medication options or medications versus other treatment modalities, and that's relatively limited. Of course, the phase 3 study compared it to topical timolol. But I think we would look at this as saying that each one of these buckets are effective at lowering intraocular pressure. And then one would look at individual reasons why one bucket may be chosen over another, such as a history of noncompliance or medication-related side effects or concerns that someone may not follow up. Things like that may lead you to a more prolonged patient-independent therapeutic intervention.
Dr. Emmerich?
Thanks. I would just add to that, there's some evidence from the Bacharach 2024 study that looked at the iDose subgroup on a PGA at screening, 133 patients, and then compared that with their in-study iDose IOP at month 3, and did find that the iDose lowered the pressure more by 7 millimeters of mercury compared to the the screening IOP of about minus 5.76. And there was a p-value of 0.003 on that. So good evidence from that study that the implant did better than topical. Thanks.
Thank you both. So most of these studies are, as you had said, compared to the topicals, right? So what evidence would be used to address these other potential? I mean, there's a lot of different treatments available, thankfully, for glaucoma. So how would you make the determination of this or that? We'll start with Dr. Wandling, who I'm assuming is going to answer the previous question, but if he has any comments on my question, please go ahead as well. Dr. Wandling.
I'm focusing on question 3 here. I'm just going to go A, B, C, D real quick. So medication alone, sometimes it's mostly an intolerance issue or a burden of the patient administration or continuing to decline despite reported adherence to the medication, and so medication alone, it's intolerance and other issues. Mixed procedure, I don't see it as an or, and there's not evidence at this point to compare it because it's too new of a delivery system. But studies will show that when we do MIGS, we oftentimes will have to treat with medication after the fact. And so this is just another delivery mechanism for a medication. And so I don't see this as a MIGS. We're not saying MIGS or drops, we're doing MIGS and drops. And this is just another delivery mechanism for this drug. Right now, Part C, there's really not on the market at this point in America extraocular therapeutic options for glaucoma drug delivery that are widespread. Maybe there's some devices that I'm not familiar with, but there's nothing commercial that has really come across our area. And then the last one, other platforms, I don't have a good rubric for when I'm choosing the bimatoprost, which is made by AbbVie versus the iDose. Other than in our group, it's opinion, and there's no evidence. There's no head-to-head right now, but I believe that both are very effective. Thank you.
Thank you. I saw Dr. Chopra was next. Please go ahead.
Yeah, thank you. So I think, as ophthalmologists, we really underappreciate the burden of medications. It's and really the amount of non-adherence. I mean, multiple studies actually, a dozen or so, have shown that non-adherence or poor adherence, is highly prevalent. And as doctors, we're not able to tell. We all think that our patients are the most compliant because we're good doctors. But really, if you look at studies, one study showed nearly 50% of patients discontinued their initially prescribed drops within 6 months, and 90% intermittently failed to refill their prescriptions over a 3-year period. So non-adherence is hugely prevalent. So having a way of delivery of medication that doesn't have adherence issues is a huge plus. Plus, I think as was mentioned, local and systemic side effects. Often we see patients with this incredibly, red eyes, and we expect them to just kind of deal with that, and that has obviously quality of life issues, and they may be non-adherent because of that. So if you can minimize those things, I think that is one way, medication alone. As far as mixed procedure, now again, most time glaucoma requires more than one thing, especially as the disease progresses, and it always does progress with age. But they're really fundamentally different. MIGS are surgical intervention. This is a drug implant. You often need concurrent things to really lower intraocular pressure. But since we don't have enough data to say, one should be done before the other, but most of the time you're going to do the less invasive procedures. Like SLT is an effective treatment of glaucoma, and you likely are going to, do that before you do a surgical intervention. So usually we would start with the less invasive ways of lowering pressure, and then go to the higher. And this also is supported by data from another landmark trial called the Collaborative Initial Glaucoma Treatment Study. So this is a study that was done in patients with glaucoma, and they were randomized to surgery first versus medications or other non-invasive procedures like laser first. And what it really found is that at 5 years, if you can lower the pressure adequately, there was no difference. And at 10 years, surgically offered just minimally more effective improvement over medications or lasers. So if you can find a way of delivering a medication into the eye safely, then that is usually you're going to start with that rather than going to surgery. So that's how we look at it, just less invasive. But at the same time, you have to lower the pressure enough so that the patient doesn't get worse. And you have the best opportunity to do that in early disease before they get to the cliff where they're going to go off the cliff and have vision loss. Thank you.
Thank you. Dr. Cothran was next.
Yes, thank you. This is a disease that disproportionately impacts some very vulnerable patient populations. patients of lower socioeconomic levels, and also the elderly. In the first group, there's a publication from Kim et al., and it was an American Academy of Ophthalmology paper in conjunction with the American Glaucoma Society from 2023 that looked at transportation and lack of transportation among patients actually directly impacted the ability for them to obtain glaucoma care and led to worse outcomes. And so if we, and that's just not transportation to our exams, but transportation to the pharmacy to acquire medication. And so I agree with one of the previous doctors that this particular device that we have in discussion it is a prostaglandin analog, but it's the delivery system that is superior than the bottle itself. If a patient doesn't have the ability to access the bottle of medication by going to the pharmacy, access the follow-ups for us to maintain that they're on the medication, or the other vulnerable group of patients are patients that are elderly, patients that suffer from autoimmune disease that have poor installation technique. Rajnala et al. Did a paper in 2022 that evaluated patients on how well they could actually instill drops. And patients evaluated themselves, and then an external evaluator evaluated whether they were good instillers or non-good instillers, essentially poor instillers. And those with poor technique for installation, 100% of those patients progressed in glaucoma, with some with visual field defects within 5-year time period. And that's a very short period. And it was a fairly highly powered trial. And so I think that we have to think about not just immediately what's happening at this moment in time of what lowers the pressure, but what will keep the patient safe in a longer term along their glaucoma journey. Thank you.
Thank you. I do want to put a pin in a question that one of the questions I would have is with the trials, if this is a consistent problem of patients non-adherence, how would that affect the trials? But we'll get back to that later. Dr. Mansberger and Dr. Liebman, I saw your hands. To keep the thing going, we're going to go to question number 4. If we have time, if you can come back to those questions that you had on number 3, or actually answers you had for number 3, that would be great. But let's move on to the next question just to keep on time. So question number 4, does the evidence demonstrate if there is a decrease in risk of patients progressing to glaucoma, OHT, or worsening glaucoma? In other words, can we determine if this device reduces the chance of vision loss over time? If yes, what evidence do you consider supporting this and why? And just to add to this question, a lot of the studies address the drop in intraocular pressure that is seen with this device. But is there studies and is there information as to that actually having an effect on the glaucoma, understanding that the main target in the treatments is the intraocular pressure? So whoever would like to go first, please let me know. Dr. Mansberger, please go ahead.
No, I think the question is whether this device has shown decreased chance in vision loss over time, and those studies I think are being done, but it has not been shown at this time. However, it does show, as we said, robust IOP lowering, which we know is highly correlated with both structural and functional loss over time. So it would be quite obvious that IOP lowering with this device would lead to decreased structural and functional worsening. And it's just important to mention that these studies to look at structure and functional worsening usually take several years, 3 to 5 years, where so far, these medicines are demonstrating efficacy by IOP lowering, and those studies are much shorter. So these type of studies to determine the effect on structural and functional progression take a much more time.
So when you say they take much more time, one of the things that I noted in the studies is that the standard that's being often used is the perimetry, and there's less information in the studies that were cited here about OCT and the other structural things. So is there a push to incorporate other methodologies of assessing, and are those methods going to accelerate the effect that we can determine whether or not this helps vision loss?
Yeah, there are. There's fancy ways of testing function with multiple visual fields at a start point, which is called cluster analysis. I think somebody earlier mentioned more rapid visual fields during the course of the study can pick up progression and decrease variability. And then right now, the structural endpoints are still being worked out. But, structural testing, as we mentioned earlier, was a much more effective way of picking up progression earlier before functional loss.
Great, thank you. Dr. Imami, I think I saw your hand next.
So I think there's really good evidence showing that intraocular pressure reduction reduces the risk of glaucoma development and the risk of glaucoma progression along the entire spectrum. If you look at the ocular hypertension treatment study, early manifest glaucoma treatment study, advanced glaucoma intervention study, all of those studies show that intraocular pressure reduction is a good proxy for prevention of visual field and optic nerve damage down the road. And I also think that if you look at the collaborative initial glaucoma treatment study, you get pressure lowering effect, as was mentioned, both from medications and from surgery. They had more pressure lowering from surgery, but both of them lowered pressure significantly to slow the rate of progression. So I think it doesn't matter so much, at least in a big spectrum of people, whether you lower the pressure with medicines or with surgery or how you do it, as long as you get the pressure down and you effectively get it down for a prolonged period of time. And it seems like this intervention shows that that's a very achievable goal. So how it's done, this is one way of doing it.
Great, thank you. Next one I saw was Dr. Wandling.
Yep, just this number 4. So Oates trials been brought up many times. They were blind to which drug were they using to actually get that 20%. This is just another delivery of a drug to help us get that 20% down. And so then that NIAC showed that the study with changes in individual glaucoma progression, talking about velocity. So this should be able to deliver the same slowing of velocity as other drugs.
And do they show the same slowing, or is it just point wise? So obviously some trials look at point wise, some look at velocity.
Right, but the Oates trial was blind to which drug are you using. So it's right, and so you could just the same. You would say, well, we got 20%. It doesn't matter really how you're getting there, as much as that you're getting there.
Okay, thank you. Dr. Cothran, you were next. If you're speaking, Dr. Cothran, you're probably on mute.
Thank you. Thank you. The body of evidence that currently exists for this particular device does not show a direct slowing of progression for patients that have glaucoma, but we do know from the early manifest glaucoma treatment trial, one of our landmark studies, that shows that for each millimeter of mercury of pressure reduction within the first few months of treatment, the risk of glaucoma progression actually decreases by approximately 10%. And so it isn't the device itself, but just moving the pressure down to a lower rate, as we talked about in the first question. And another doc had mentioned it takes multiple years for studies to actually show, if there would be a change in progression for this particular device. The device has medication that eludes over a certain period of time that may not last long enough into the number of years that it would take, for example, for a set of data like the Horizon data that went out 5 years and actually showed a decrease in field progression. And so I think that if that type of body data would be there, it would need to be one of these devices that was removed and then replaced with a new one, because the medication does eventually wane in time.
Thank you. Okay, let's move on to our next set of questions. That's the first 4. And again, I wanted to thank you very much for citing so many studies and providing so many informative evidence citations. If you can send anything that you don't see to us, so in other words, citations that we should be looking at, we greatly, greatly appreciate that. Okay, so question number 5 is, based on the evidence, what patient criteria should be considered for the use of the travoprost intercameral implant. And then there's some sub-questions here. Is there evidence to support use in mild to moderate OAG? And what about severe OAG? And then is there a range of intraocular pressure that would be appropriate to use this device for ocular hypertension? And if so, what range? What are the absolute contraindications for this technology? What are the relative contraindications for this technology? And then what patient criteria, e.g. medication non-adherence, physical inability in using drops, etc., would you consider relevant in selecting patients for this device? What documentation should be required? And I know that we've gone over some of this, so if you can focus on the areas that we haven't touched upon yet, that would be great, but feel free to reiterate some earlier points if that helps the conversation. Thank you. Dr. Ramani. Dr. Ramani, did you want to speak?
Sorry, the collaborative initial glaucoma treatment study looked at medications versus surgery for treatment of glaucoma. But there was a subgroup of people who had advanced glaucoma in that study where it was felt that the lower intraocular pressure potentially obtainable by surgery was possibly a better initial intervention as opposed to both interventions being relatively equal. So that could potentially pose an interesting point here with this implantable device, where if compliance or adherence was potentially lowering the effectiveness of the medically treated arm in that study, and you use an alternate form of medication which removes the adherence piece from it, then it may potentially place it as a better intervention for advanced glaucoma as opposed to some of the other options, such as using medications early.
Thank you. Dr. Rosedal.
Hi, this is Julia Rosedal. No conflicts, thank you. So just with regards to this question, the evidence to support the intracameral implant in mild to moderate open angle glaucoma, I think that's where, these pivotal studies shine. These are the patients that they used for these studies. So I think that's where the strongest evidence is to support the use of this device. Because of the way the studies are done, they do a washout period. And so that, allows the pressure to go up temporarily to really get, the readings that helps show the effect of the device. And that washout period just isn't always safe for a patient with severe open angle glaucoma. And so they weren't necessarily included in the studies, but that doesn't mean that that wouldn't be really useful for these patients as well. So I think that's where there's a little bit of an evidence gap, but that doesn't mean that those patients wouldn't benefit from it. And then for B, is there a range of IOP that'd be appropriate? I think here it's that IOP, like we've talked about, that we feel is dangerous for patients where they would have progression. And so it would really depend on, what each individual patient and what they need. For the absolute contraindications, I think we'd all agree we wouldn't want to do this in a patient where there's an infection, active infection, where there's no view to the angle, where you can't access the angle. If a patient's really not able to position to do the surgery safely, or if there was really risk for penetration, a patient with a corneal dystrophy, or where you can get that device in safely. And then for relative contraindications, a patient where you weren't sure about the angle, you weren't sure you were able to get it in there, with neovascular glaucoma or uveitic glaucoma, potentially, if the patient was really quiet and the angle was amenable, you might consider that this device in those patients, but I think that would be a relative contraindication. Certainly with corneal diseases like Goutte or sutured IOL, caution with aphakia. You want to be careful also in patients that have had prior angle surgery like a goniotomy or a trabeculotomy, where you weren't sure that that device would sit there. And then for E, the patient criteria, I mean, that's a nice list, and these have come up in the past, what the other doctors have mentioned, you know, patients who just cannot get medication into their eye for whatever reason, mental or physical, you know, covered this a lot, so I won't go over that more, but that's my input.
Very thorough. Thank you very much. Would anyone else like to speak to this question? Dr. Cothran? And then I think I think Dr. Liebman was just right before you. So go ahead, Dr. Liebman.
Thank you. Yes, Dan Liebman, Mass Eye and Ear, happy to be here. No new conflicts to disclose. I think Dr. Rosdell did an exemplary job of going through a lot of these. I think just a few points that I will highlight, kind of especially in light of the pivotal trials with regard to I think that the pivotal trials are to be commended in some ways for taking on a large range of types of glaucoma. I think emphasizing that open angle glaucoma encompasses a range of conditions: pigmentary glaucoma, pseudoexfoliation glaucoma, secondary open angle. The pivotal trials did enroll patients across the full range. So I think emphasizing the full range of open angle glaucomas was included in the pivotal trials, and generally showed good response kind of across. So to my eye, the device really is certainly indicated across the range of the different open angle glaucomas. I think the ability to implant the device to me is the number one when it comes to contraindication or lack thereof, and the ability to document that the angle is in fact open enough to be able to seat the device, to keep the device away from the cornea. So having a deep enough angle that the device can sit in there, and then certainly, like Dr. Rosdell mentioned, having neovascularization or other factors in the angle that would preclude its safe placement, really to me are the main absolute contraindications. Relative contraindications certainly would involve the ability to corneal diseases that certainly haven't been. I think the data isn't there on those patients were excluded from those trials if they'd had corneal transplantation or other issues. To me, it's not necessarily an absolute contraindication if there are pressing arguments for why a patient needs to have their pressure lowered and cannot use topical agents. In some of these cases, it could be considered on a case-by-case basis. So to me, a lot of these corneal issues are more relative than absolute. But the ability to place the device in a range of open angle glaucomas, I think, is very well supported by the pivotal trials, and documenting the ability to place the device safely, I think, and a relevant reason for why the patient needs the device, either an intolerance or an inadequate response to topical agents, or an intolerance to topical agents, or poor adherence, I think would be appropriate to document for the use of this device.
Thank you. Now, I can't remember, the hand disappeared. Was it you, Dr. Cothran, that was next? And then I saw Dr. Wandling wants to speak as well.
Yes, thank you. I just had a comment on the question 5A, the second question. I agree with the previous doc about the ability for severe patients to be precluded from some of these studies because the danger of the washout period to be included in these studies could allow the disease to become unstable in order for them to be enrolled in this study. I think it's important for us to recognize that even outside the particular study for this particular device, for patients that have severe vision loss from a public health perspective, it's very well documented in the literature that patients that have severe disease, severe vision loss from diseases like glaucoma, macular degeneration, they not only suffer from higher rates of depression and anxiety, which increases there's an increase in the economic burden, but also the psychosocial burden, but they also have higher rates of all-cause mortality. And so if you have a patient that has severe glaucoma who is responding to a topical prostaglandin and their pressure is at target, and then to question 5E, and there is something that is limiting them from being able to utilize that prostaglandin, then those types of patients, I think, are perfectly appropriate candidates, and it would be perfectly reasonable for them to be able to utilize this device.
Thank you. Dr. Wandley?
Yep, just quickly, 5B. I really think it's a mistake to try to put a range on the IOP. Again, as previously mentioned, washout is not always possible. Washout is going to give a false sense of what is their pressure, without doing a washout, what is their pressure, treated, untreated, et cetera. And you don't want to put a cap on it because sometimes you just have to throw everything at the problem to get the pressures as low as possible. And so I really think putting a range on when is it appropriate to do certain interventions in glaucoma is a mistake. Thank you.
Thank you. So let's move to our next question, which is already overlapping this question. What would you consider the limitations and strengths of the referenced papers, which represent pivotal papers used for FDA clearance of the device? And we've already addressed this a little bit with the washout period in patients with severe glaucoma. But if there's other things that you would like to mention as limitations and strengths, please raise your hand and we'll get to you next. Dr. Rosedale, my apologies.
Thank you. So, just a couple other strengths. A randomized clinical trial, the placebo drops that were used with the iDose. So I think that's a strength, how they designed it, where even the iDose group was using placebo drops and the timolol control had a sham surgery. So I think they were thoughtful about their control. The studies used United States sites. They were done here in the United States. They had the washout, as mentioned, out to 3 years. They used masked IOP measurements. Can't really be masked to what the surgery was for the surgeon, but they really worked hard to make that as robust as possible. They did measure corneal endothelial cell counts, and they did measure the visual field, the Humphrey visual field. I think number of limitations, just like with any study, the study is perfect. I wish they would have included patient-reported outcomes or satisfaction assessments. Wish they would have included OCT. I think it would have been interesting to find out about the patients who did not stay enrolled in the study group, and then some of the results they reported where the iDose group kind of seemed favored with how they described the proportion of patients on fewer topical medications. I wish they would have really stuck with kind of total medications on that. So those were the things that I thought were kind of notable about the papers.
And would have mentioning the types of medications that they were on, would have that helped as well? They mentioned that the number of medications, but would have mentioning the types of medications have made any difference?
I think that the way they designed it, where they had the iDose compared to timolol, I think that makes sense, had to design it that way, because that's a lot of the medications are compared to timolol to get approval. But it kind of limited then what medications you could add back, because if you're masked and you're not sure, whether they're taking the timolol or the placebo drop, what you can add back. I think that kind of limits what you can do for the patient. So certainly seeing what medications they added back, but I think, thinking about the total medication burden, is useful to see.
Thank you. Dr. Emmerich, and then we'll go to Dr. Chopra after Dr. Emmerich.
We haven't discussed too much the Durista studies. We did mention earlier one limitation of some of the studies we've talked about is that it's really just looked at IOP. One of the Durista studies did look at visual field progression over an 18-month period and did find a difference in visual field loss between the Durista group of less than 2 decibels and the timolol wing, it was about 8 decibels. So there is one moderate term study out there showing efficacy in terms of reducing visual field loss.
Thank you. And we'll get to the Durista in later questions as well. And so this can be brought back up. Yeah, no problem. Dr. Cawthron, I do see that your hand was listed as the first, but since I promised Dr. Chopra next, I'll let him go next, and then we'll get to you next. I apologize.
Thank you. So I think, you raised a really good point about knowing which medications. Typically, I don't know if that would make that much of a difference. What happens in medications, as you add medications to a particular patient, is that the first intervention always gets the most bang for the buck, then the second one a little bit less, the third one a little bit less. And usually there's generally speaking, kind of a known regimen in how we proceed. Typically, most patients start with prostaglandin analogs, and then second treatment may be a beta blocker or alpha agonist. And sometimes, you might use a carbonic anhydrase inhibitor. Part of it really has to do with, you have to choose the right medication for the right patient based on side effects, intolerances, and their adherence issues. So if you can use medications that are less needed, you don't have to do it, twice a day or 3 times a day. Those are typically preferred. So that's kind of how you think about it. But I don't know if it would have made any difference knowing which medications they were on, which 3 versus, 2 versus 1. But that, would be useful information, but I don't know if it would have made any difference in the trial. And the second thing is, in the iDose studies, there was reported visual fields. I can't remember, was it phase 2 or phase 3 trial where they showed no difference in progression in outcomes. Now, the thing is, all 3 groups, timolol, the fast eluting and the slow eluting travoprost were reducing the pressure. So pressure reduction was achieved in all 3 groups, and hence you would not expect any really differences in visual field progression. But there was that, in addition to what Dr. Emmerich said about the Durista study, but in the iDose study, there was shown that visual fields actually did not progress, but unfortunately they didn't have information about the OCT. Thank you.
Thank you. Dr. Cawthron, and then I have a question about this one for the group.
Yeah, I do think one of the limitations was running head-to-head against timolol. I know at the time that the FDA was for this, both and the pivotal trials for the approval for the bimatoprost sustained release, timolol was considered the standard of care, and now all of the newer studies that are moving forward after these particular studies are utilizing prostaglandin analog as the standard of as the standard of care and as the comparator. I think it is important to recognize that the mechanism of action of timolol is different than a prostaglandin analog. And so if you have if you have some patients that may have been on, one particular drug class before and were responding really well to it, even though the angle is open, there are some aspects about the genetics of patients that are a little different in how they respond to medications. But I think it is just something to take into consideration that running the study against actual, topical prostaglandin analog would have been a little bit more robust data.
Yeah, that'd be very interesting if that study would be done. Before I get to you, Dr. Liebman, the question I had also for the group around this was about limitations in regards of how long the follow-up was. So the FDA clearance was based off of 12 months, I believe, right? So do we have any addressment for the prolonged use of this and its effectiveness for longer periods of time? And I'll let you go, Dr. Liebman, and then I'll see if anyone has an answer to that question. So go ahead, Dr. Liebman.
Sure, I can speak both to that and to, I guess, so I'll speak to that to quickly follow up on the point around comparison to timolol. I think, yes, it was both the standard of care of trial design at the time that this was done. This is not the only one that compared to timolol. Certainly, a comparing of like to like is a little bit different. I will just point out Bacharach's 2024 subgroup analysis did at least look at pre-post IOP for patients, for the subgroup of patients who had been on a prostaglandin prior to the study, and did show a comparable. In fact, if anything, there was a slight, I think it was minus a 7 millimeters mercury reduction for the iDose, with a 5 millimeter or 5.7 millimeter reduction pre-washout with their previous topical PGA. So it's certainly not the same as a prospective comparison, but we do have a subgroup analysis at least looking at those exact same patients who had previously been on prostaglandins who still did show good efficacy with the iDose. So certainly, yes, it'd be nice to have the other comparator group, but I do think that at least serves to answer that question to some extent. To your question around the length of follow-up, yes, I think yes. So the phase 3s were 1 year. We do have Burdol's. The phase 2 does put us out to 3 years, and in addition to that study, I think we do have a smaller. I'm going to not pronounce the name properly. I think it was Shekeli, Czekely. Shekeli had a follow-up that kind of looks at some of these devices after explantation around the 3-year mark or around the 2-year mark, still showing probably about a year's worth of medicine left inside them. So on the one hand, yes, the device is only designed to really elute medicine for up to around 3 years. But I do think that this time course is at least reasonable for the type of device that we're looking at.
Thank you. And just correct me if I'm wrong, but I believe it's 2 years, right? iDose is set for 2 years. 3 years was the period of time where they saw continued.
So the follow-up lasted for 3 years, and did show continued IOP reduction for a substantial proportion of the patients out to that point. And then the other reference study I was mentioning is just kind of gives a little bit of a pharmacologic or pharmacokinetic potential basis for that, which was examining the devices that had been explanted around the 2-year mark, still showed a reservoir of, I think, around 16% of remaining medicine. So projecting out would be expected to probably have a meaningful IOP lowering effect for around 30. I think 30 months was sort of if you graphed out the amount of residual medicine, and then plus or minus any residual effect similar to what you sometimes see with Durista after the medicine is physically gone. But yes, 2 years for the device, but 3 years for the follow-up period, and around that much for efficacy in terms of IOP lowering effect.
Thank you very much. Dr. Emmerich?
Yeah, thanks. I was just going to speak to a little bit more the Burdol study that Dr. Liebman was referencing, and this relates a bit to what we'll come back to in question 9 on long-term safety, but this was the phase 2B study that followed patients for 3 years with comparable IOP lowering out to that 3-year mark, and with the percentage of eyes on the same or fewer topical medications at 69% in the iDose group versus 45% in the timolol group, and found it to be very safe at that 3-year mark. No significant difference in endothelial cell counts, and continued efficacy at that point. It is a smaller study. There were 54 patients in the iDose group and 49 in the timolol group, but fairly convincing and robust data. Thanks.
Thank you. So let's move to our next question, question number 7. So the pivotal studies demonstrate non-inferiority of the travopost intracameral implant as compared to timolol drops. Do you consider this sufficient evidence to recommend the implant as a standard of care? And then if no, what criteria would you consider before recommending this device as an alternative to standard of care medical management? And if yes, what evidence influences that recommendation? Dr. Liebman.
So I think we've sort of discussed the point of the comparison to timolol already, but I guess I would circle back to saying I think the evidence, ultimately going back to the top of this discussion around the central importance of IOP lowering as the really the only modifiable risk factor for glaucoma. I think the real question to me is does a device like this meaningfully and sustainably lower IOP to to a degree that I would consider to be clinically meaningful. And to my eye, the pivotal studies do say, yes, we see robust IOP reduction, certainly commensurate with timolol. Also, again, referencing the Bacharach subgroup, looking at, also commensurate with a prior topical prostaglandin use, in a way that I would expect to be clinically meaningful for glaucoma patients. So I think, I suppose the question of standard of care, to be honest, the standard of care for glaucoma is to lower IOP to a degree that is likely to lead to reduction in the rate of progression of glaucoma. And typically, again, I think we've previously discussed around 20 to 30%, at least as an initial goal, and some patients need more. So to the extent that this device can be a part of the armamentarium to accomplish this, I think the studies do show that this device serves to lower pressure, as opposed, around what, where does this stand within the armamentarium? I think, glaucoma is an inherently personalized, there's an inherent personalization to each and every patient's care. So, where this stands within, I think the evidence is sufficient to show us that this device does do what it is intended to do, which is lower the pressure. Where that should stand in the armamentarium when it comes to other, either drops or SLT, I think that is, inherently an individualized patient level discussion, but kind of goes back to what we were discussing before around patients who require pressure lowering, for whom topical agents are not functional or not working for the reasons we've discussed, and certainly as an alternative to other more aggressive or more invasive means of lowering eye pressure. I think the data does support this device within our armamentarium for use.
Thank you. I think I saw Dr. Chopra's hand up, but he put it back down. Dr. Chopra, did you want to say something?
Yeah, I just wanted to say, I agree with Dr. Liebman. I mean, there's this trade-off that exists between safety and efficacy, and you really do have to individualize care, as you mentioned. In patients with more advanced glaucoma or rapidly progressing glaucoma, in patients who we call catastrophic visual field progression, more than 2 decibels of visual field loss per year, you have to do a much more invasive procedure, and then the risks of that is acceptable because the alternatives of blindness is much greater. So, I think it's good to have the full armamentarium, as we said, because glaucoma is such a heterogeneous and a disease process that really is a full spectrum, and patients are simply living longer, and you need to do, somewhat earlier intervention, certainly with less invasive things, MIGS surgeries or the intracameral implant perhaps, but having that option, I think, is incredibly valuable. Thank you.
Thank you. And then, so one follow-up question, and then we'll get to Dr. Cothran. Would this be considered ever a first-line treatment?
I would not consider this a first-line treatment, except as mentioned, I think by Nora Lee and others, where in certain patients, say if they exactly have shown effectiveness to a prostaglandin analog, that's the medication that works really well for them, but they develop ocular intolerance because of preservatives in the medications, or just in general with periorbital orbitopathy, then you can put this device in and lower the pressure equally well if they were controlled before. So in that case, I would say, okay, fine, do this as a first-line intervention, but perhaps not standard of care over medications, if you were to ask my opinion, because it is intervention. But in certain patients where if they have arthritis, they can't put the drops in, they're older, mentation issues, then certainly this would be a primary option.
Thank you. And then you guys can answer, the rest of you can answer the question that I just asked as we go through the list. So next is Dr. Cothran. So please, Dr. Cothran.
Thank you very much. I agree with Dr. Chopra. I, as a non-surgeon, I would not be able to recommend this as a standard of care because I feel prostaglandin analog topical therapy is the standard of care. And within the optometric space, you have optometrists in all 50 states that are actively managing the early forms of this disease. And so I think it's really important to think if we start labeling a surgical intervention as the standard of care, well, then now you have an entire group of healthcare practitioners in the United States that are actively managing this disease that would then not be participating in the standard of care. And there just simply aren't enough glaucoma surgeons and anterior seg surgeons out there to allow this in standard of care. I do believe that all surgeons should have this in their therapeutic armamentarium and the ability to use it in those appropriate patients that have proven to respond to prostaglandin analogs and just don't have the ability to effectively get the medication into the eye.
Thank you very much. Our next speaker would be Dr. Imami.
So I think that, again, there's clear evidence that this is a very effective treatment in a significant group of people who have glaucoma. And we've talked about its effectiveness and we've talked about the safety piece, very important. I also think there becomes a value piece that needs to be considered as we look at society's limited healthcare resources. And, for example, what's the pressure reduction per unit value of cost for what's being done. And that also, I think, needs to be considered as you look at this as an earlier intervention versus potentially a more value-based intervention first, assuming everything else is equal from an efficacy and side effect perspective.
Thank you. And then lastly for this question, and then we'll move on to the next one, Dr. Wandling.
I just think that standard of care is different than first line, right? And so, yes, this can be within the standard of care. That doesn't mean it's the first line for every patient, right? In general, the preferred practice pattern now has really shifted into SLT as usually the preferred first line treatment for most patients that come in the door. However, there's going to be some patients where, whether it be allergies or different things, that we've discovered that maybe this would be the first line treatment for that particular patient. And we just don't, and so it would be within the standard of care for that particular patient. That doesn't mean it's not a proper thing to recommend. And so, yes, standard of care can mean a lot of things. It's more of a flow sheet. First line preferred treatment may be a different recommendation, or whether that be drops or SLT in most 8% of patients. Thank you.
Thank you for providing some definitional clarity. Thank you. So next question, next slide. So now moving on to Durysta. Durysta bimatoprost implant dissolvable is a sustained release medication for lowering IOP for glaucoma or ocular hypertension after insertion into the anterior chamber. The FDA label approves this for single injection. How do you determine patient selection for this device? Does the evidence support effectiveness? Is there any evidence to support use of this in combination with MIGS procedures or other glaucoma managements? And is there any evidence to support repeat administration of this device? Dr. Cothran.
Thank you. I think I can speak a little bit for this. The way the the clinical trials for the phase 3 data were set, where the bimatoprost implant was, eludes medication over the course of 3 to 4 months, and the trial was set up to place a pellet into the anterior chamber at particular intervals. And these pellets were then stacking up into the anterior chamber, coming into contact with the endothelium. And because of the endothelial cell loss, I presume is why the FDA labeled it for a single injection use only. The medication or the MIG does have the potential to lower IOP much longer than the medication is eluted. And there were some discussions within the glaucoma community, and Dan Stamer had a very interesting paper in 2023. It was discussed when our AGS meeting was on lockdown, and the paper was published just 2 years ago that looked at the placement of bimatoprost into the anterior chamber versus on the eye itself as a drop resulted in upregulation of MMPs, which, or think of it like the street sweepers that keep the trabecular meshwork clean and clear out the extracellular matrix. And that may be the ultimate mechanism of action by which, even though all the medication is eluted, that patients are still achieving lower pressure even months and years after study. A recently published paper this year by Dr. Mann and his colleagues found that known as the ARGOS data set showed that at the 18-month mark, about 77% of patients still had lower controlled IOP, even though for some patients, even my clinical practice, the vehicle is completely eluded. And so I don't see any major contraindication for repeat administration of the device, because the repeat administration would more than likely be done at a much longer interval than the 3 to 4 months that were utilized in the phase 3 clinical data. Thank you.
Thank you. Dr. Wandling?
Yeah, maybe I'm misremembering and someone can speak to this, but I believe that's the stacking or the endothelial cell issues were really only with the larger device, and that's why the company chose the smaller device and to put to market. And they really didn't show that endothelial cell issue. If you've seen them implanted over time, you will see that the device significantly gets smaller over several months to the point of where it really shouldn't be significant when you're doing a repeat injection. So D, is there any evidence to support? Yes, they were doing repeat injections. C, is there any evidence to support this in combination with mixed procedures? I don't believe there's strong papers out. I will double check that and submit any if I find any. Evidence B, does the evidence support effectiveness? Yes. And A, how do you determine patient selection for again, it's going to be the similar things: intolerance, inability to place the drop, dry eye, and sometimes it's just dry eye is all we're trying to accomplish, and just getting a patient off of another topical is really beneficial for that patient. Thank you.
Thank you. Dr. Liebman, you were next. If you're talking, Dr. Liebman, you're probably on mute.
Oh, I apologize. So yes, just to follow up on the question. Yeah. So within the Artemis studies, the pivotal trials for the bimatoprost implant, there were 2 sizes that were being studied: a 10 and a 15. The 15 was 50% larger. And was not ultimately brought to market. The 10 is kind of what is now known as Durista. I guess I'd emphasize that the trial use of the device does not mirror current practice. They injected it on at 4-month intervals, something that we no longer do. They did show there was some endothelial cell loss even with the 10, though again that was with there are some photos, gonioscopic photos within those studies where you can see 3 different devices stacked up into the angle at once. So I think, the current thinking is spacing things out to a greater extent such that you don't have multiple devices in the angle is considered advantageous. I think the evidence did support effectiveness, at least over the course of the expected use of the device. With the question of MIGS, to my knowledge, there aren't any major trials looking directly at them, though I would kind of emphasize that MIGS procedures generally work on outflow, enhancing outflow of aqueous, whereas these both the bimatoprost implant and the iDose, all these devices that we're discussing are more around enhancing uveoscleral outflow. So one could expect there to be a complementary effect since they are different mechanisms of action, though I don't believe there is long-term data to that extent. In terms of use of this device versus this is an office-based procedure, so there are certain advantages to to an implant that can be done at the slit lamp in the office as opposed to needing to go into an operating room space, such as the other device that we've been discussing here today. So relative strengths and weaknesses for both, but both efficacious in their own degree.
Thank you very much. Dr. Mansberger and then Dr. Rosedal.
This is Dr. Mansberger. I had nothing else to add to this other than I agree with the previous things. And thank you.
Thank you. Dr. Rosedal?
Yeah, I just wanted to mention that the Durista is an office-based procedure where your patient's sitting at the slit lamp versus the iDose in the operating room. And Dr. Liebman mentioned that. So I unraised my hand, but not quick enough. Thanks.
Great. Thank you very much. So let's move to our last two questions then. Moving on to 9. So question number 9 is, both the pivotal studies and real-world data have demonstrated safety of the device in a short-term setting ranging from 3 to 24 months. And we're back to talking about the travoprost intracameral implant. Do you have concerns about the lack of long-term data on effectiveness and safety? And if yes, how do these concerns impact your decision-making in patient selection and use of the device? And if no, what provides you with reassurance? And we'll start with Dr. Emmerich.
Yeah, thanks. So I would just go back to the Berdahl study, which did go out to 3 years, 36 months. So there is good evidence of both safety and efficacy up to that time period. The expectation with this device is that it would not last beyond or much beyond 36 months due to the design of the implant. There are other implants. There's an iDose TREX, which with about twice the amount of medication, which is would of course last longer, and so that has a lot of appeal. That it would not require replacement as quickly. But there, again, good evidence that there is 3-year efficacy and safety for this, and the Berdahl study demonstrates that nicely. Thanks.
Now, is there good studies out there addressing removal versus leaving it implanted and adding another one?
Right.
That would be another one of the safety questions, is that once the device is spent, is it left in place? And if it is removed, is there any safety concern with that?
Right. I think anytime you go into the eye, there is concern about the corneal endothelial cells, and there are continuing ongoing studies that are looking at the safety of exchanging the iDose. And I think the FDA is planning to review that sometime in January, the latest data on that. Removing the device technically should be relatively easy, and replacing it, not a concern. Again, it's just the going back into the eye to have to do the replacement, and again, that's the appeal of a longer term device. But we don't have the data on the safety of the exchange procedure yet.
And is there any concern with you or any of the group with the idea that the removal hasn't been fully elucidated in the studies yet?
No, I think we're just waiting for the data again. That the expectation is that the efficacy is going to be equal to the first implantation. There would be no reason to question that. Again, we'll see what that shows. The concern is just, again, the safety with the endothelial cells with the exchange, and we'll be awaiting further data on that. And again, I think the FDA plans to release its kind of opinion on that in late January.
Thank you. Dr. Liebman?
Yeah, I would say I would second, a lot of some of this data is still forthcoming. The Shikeli's study from 2025 does involve the removal of, I think it was 210 patients total with removal of the iDoses. no noted, in terms of the safety of removing the device, no significant issues were noted in the process of removing those devices. Again, that was for the purposes of studying the residual contents of the iDose, but the device itself appears to be relatively straightforward to atraumatically remove. So, while we await, kind of find definitive data on that, I think you could at least look to studies of that nature to look at, at least the device has been explanted on a number of occasions under a controlled setting in the past without any noted substantive complications.
Thank you. I saw Dr. Wandling is next.
Just echo removal endothelial damage, but again, a lot of times that is addressable. If you have something, we can't get back the vision we lose from glaucoma, and so we want to continue to lower the pressure. We can oftentimes fix endothelial cell damage with a DMEC, DSEC, and other things. And there's really promising injections on the horizon for replacing those cells. But additionally, the other thing that you'll hear is there's anytime you go in the eye, there's a chance of endophthalmitis, although it's pretty darn small. But those are the things that are going to come up with any kind of repeat injection, whether that be a Avastin or a Eylea, a Durista, or replacing an iDose. Thank you.
Thank you. Dr. Cawthron?
I think it's important to note that one of the limitations of the Shikeli study was it was done in Armenia, and 100% of the patients were white. And glaucoma is a disease that disproportionately impacts African American and Hispanic patients. And the genetics literature does show that there is a difference in particular genes and maybe some of the dysfunction that may be there within the trabecular meshwork, or potentially how patients may respond to explant healing, scarring, things like that. So I look forward to the data that the FDA is reviewing for explant in American populations, and hope that the demographic is broad enough to actually cover the types of patients that we care for in our communities.
And thank you for bringing that up, because you do bring up another kind of side question with that, especially with some of the earlier studies. It does look like most a lot of the earlier studies were more Caucasian ethnicity than anything else. And does that have any influence on your ability to extrapolate it to the rest of the populace in the United States?
I don't have the ability to extrapolate it, as I don't have a background in, epidemiology or even genetics, just enough to be able to analyze the data as a former data analyst from the DoD before I became an OD. But it does make me hesitant to take, one data set and then even the additional data set of the implant being administered in combination with cataract surgery that was also in Armenia, also in a completely white population. And so I think it's extremely important that we make sure that in some of these communities that may be the recipient of these types of devices, that we do have sound scientific evidence-based data that shows that it is safe within those patient populations, and that they have the same type of outcomes that other demographic of patients do.
And also in the American medical system, because I'm assuming that there would be some differences. I don't know how many, but differences between countries. There's differences, I'm sure, between states alone, but between countries at least. I think, Dr. Chopra next, and then we'll go to Dr. Emmerich.
I think the differences in demographics, I think, is an important point, but I think really it's more important when you do surgery that involves a lot of wound healing characteristics on conjunctival-based surgeries, trabeculectomies, Zan, tube shunt, things like that. But in patients who typically have MIG surgery, where the implantation and explantation is it's not involving as much wound healing. It's about a drug-eluting medication, which has actually been found to be quite effective in all ethnicities and races. So I don't think the differences are expected to be that great. I think I still would like to have the data for sure in our population, but I would expect it to still have fairly equivalent pressure lowering among all. And if you look at the studies that are the pivotal studies currently, the level of pressure, starting pressure, was not as impactful either it lowered pressures, whether the pressures were very high or not as high. So in percentages terms. So I think it is an important point, but I think in this particular case, because it's a drug-eluting device rather than actually a device that filters pressure, I think it'll be equally effective. Thanks.
Thank you very much. Dr. Emmerich?
Oh, I just wanted to point out that in the iDose pivotal trials, 19% of the patients were Black. So there was not a subgroup analysis, which would be nice to see. But there was, I think, some attempt in those trials to have a more diverse patient population.
Right. Dr. Cothran?
My concern isn't the efficacy within those populations. It's if we're discussing the explant and then the reinsertion of device over multiple times, as a lot of doctors, surgeons may be using this off-label multiple times or at the times of other types of surgeries. And so, no, I definitely recognize that there was a robustly powered phase 3 data that included patients of all different races, but my main concern would be the explantation and then the reinsertion of multiple devices.
And thank you for bringing that up as well, because that was another question to ask the panel about dual insertion. So iDose is frequently in the field inserted with iStent or performed in combinations. I know there is a study about cataracts and iDose, and I think it's a single study. If they know more studies, then please send them our way. But in terms of like with iStent and the other MIGs or other types of procedures, could you comment on that? And we'll start with Dr. Emmerich.
Yes, so on clinicaltrials.gov, there are 2 industry-sponsored multi-center randomized clinical trials. There's one that's comparing the iDose plus iStent versus iStent alone. So looking forward to results of those studies, but that's being looked at. And then the other one is iDose TR with cataract surgery versus cataract surgery alone.
There's no studies that have been completed for those.
Not completed.
Okay.
Correct.
Thank you. Dr. Wandling?
I totally lost my train of thought, sorry.
No worries. If you think of it, we can come back to it. And then this is definitely also, in addition to the Black population, the Hispanic population is also another large population to consider in this as well. Let's move on to the final question. Oh, go ahead, Dr. Wandling. You remembered?
Sorry. Yeah. So again, to reiterate, someone had mentioned it earlier, logically doing a MIGS procedure with an iDose or one of these implants should be working on 2 different pathways for helping glaucomas. And so they really shouldn't cancel each other out or have a destructive interference type of relationship there. And again, I think most people are going to consider this is a drug delivery and not an anatomic altering surgery, right? And so doing one that alters the anatomy like an iStent plus a drug delivery really should make sense. Thank you.
Though one question there would be the is there studies on effectiveness of doing these sequentially as in versus concordantly? So is there an added, because we've already talked about how there's diminishing returns on subsequent treatments, and at least that's what Dr. Chopra was talking about earlier. So is there evidence that doing these concurrently at the same time is better than doing them sequentially?
So they haven't been able to show, they haven't shown tachyphylaxis except for maybe outside of alpha-GAN, alpha blocker. Someone can mention that, but that has not been shown with PGAs. And I think most surgeons are looking at as not is this, am I going to get 1 or points difference if I spread out the surgeries, but am I minimizing the number of times I'm going inside the eye, right? Even though the chance of endophthalmitis is tiny, or just doing surgery, every time you do surgery, your risk of having drier eye increases, right? And so those are the big factors that I'm considering, at least when I'm trying to combine, when you combine surgeries, is to minimize the number of times going into the eye. Thank you.
Thank you. Dr. Liebman?
No, Dr. Wanning, basically, I was going to bring up, while I'm not aware of data to support a staged versus, at the same time approach, I agree, there's consideration of there's a certain amount of small assumed risk that's kind of already on the table when you're inside the eye doing one procedure. So yes, I would second that point. To the generally, we prefer to minimize the number of times that we expose the patient to the low but existing risks of any kind of interventional maneuver.
Thank you. We have one final question, and then we can open it up to the contract medical directors if they've been having any burning questions that have not been answered yet, and then we can close off on time. So the final question is, what ICD-10 codes do you consider appropriate for billing of 0660T, which is the iDose insertion? Starting with Dr. Emmerich.
Yeah, so I would consider all of the diagnoses that are included in the indications for iDose, so ocular hypertension, H40.05, all of the open-angle glaucomas, the H40.1s, and not just primary and pigmentary and capsular, but also low tension. I think we touched on earlier the importance of IOP lowering in patients with statistically normal pressures, so they would certainly be appropriate to include as well. Essentially, anyone who is appropriately treated with a topical PGA and has an angle that is and meets the other criteria that we discussed, that would be appropriate for placement of the iDose, would be an appropriate patient.
Thank you. Do any of our other subject matter experts have anything to add to that? Dr. Chopra.
Yeah, I agree with Dr. Emmerich, especially because sometimes the differences between normal tension glaucoma and open-angle glaucoma or ocular hypertension are quite nebulous and difficult, because if you look at the Los Angeles Latino Eye Study, which we did, it was over 5,500 patients, and in that study, the patients with defined open-angle glaucoma, their intraocular pressures were 17.3, whereas the normals were around 14.1. So all those patients who had defined glaucoma with visual field loss, with optic nerve damage, did not have elevated intraocular pressure. And pressures fluctuate all the time, as we know. So I think, it's very difficult sometimes to know whether this is a pure low tension glaucoma versus a high pressure glaucoma. Sometimes it's obvious, but other times it's simply not, because of the variation in pressures, the fluctuations in pressures. And so it's best to have it available where you can lower the pressure in a patient who has glaucoma.
So are there studies then planned for one addressing the variability in the intraocular pressure you mentioned, or you or your colleagues have mentioned that nighttime there are spikes? And then the secondary question is there move to trials to see if this methodology of lowering intraocular pressure is more beneficial for some populations than others?
Yeah, I think you raised a very, very, very important point, which actually has been discussed, in terms of how to design clinical trials. There is new contact lens coming out, not the triggerfish that's available now, that's very difficult to tolerate, but a soft contact lens that'll be able to give us a full 24-hour pressure measurement in a patient. Once that's approved and usable, then we'll actually know what the intraocular pressures are. There's a device that patients can use that can measure their intraocular pressures in the evenings, but having control of intraocular pressures throughout the 24-hour period is an important point, and that's why in this study, they had used 3 points, 8 a.m., 10 a.m. in the pivotal studies of the iDose and at 4 p.m. initial pressures to do randomization because pressures can vary. Obviously, we didn't have any data on overnight, and that would be useful to have in the future.
Yeah, especially with the normal pressure, quote unquote, glaucoma. I do want to make sure that my compatriots, my fellow contract medical directors, have a chance to ask you questions that I've missed or haven't been covered by the standard questions. I'll wait for a sec to see if anyone speaks up. And while we wait for potential questions from our medical directors, is there any other last minute things that people wanted to say that were missed or would be important for this? Remembering that we will, of course, love to get more information from you in writing, and any of the papers you all think would be that we don't have that would be important for us to look into when exploring this topic would be greatly appreciated. Dr. Liebman.
Yeah, I think this has been a great conversation. One thing that I've been hoping to just make sure is considered is the Hawthorne effect as it applies to any studies of this nature, and Hawthorne effect being the the concept within any of these studies where the effect of measuring, of patients being measured or being monitored itself changes their performance and their behavior in a way that, maybe isn't representative of real life situations. I think any of these studies where you're comparing a device or an implant to an active agent, something that requires administration like a drop, we're looking at you're looking at a best case scenario for the comparator group, which is probably not indicative of real world practice. I think it was discussed previously. There's some good data to suggest that in the real world, patient self-administration of drops is highly suboptimal. In these studies, the patients are being tracked and are probably using their drops far more effectively. So it's just one thing that I think is always worth bearing in mind anytime we're comparing, something that takes the medicine, something that takes the onus out of the patient's hands, comparing it to a previous standard of care that involves an onus on the patient, that we're probably looking at a rosy comparator and a much more probably an exaggeration of the preceding standard of care than really exists in daily practice. So just something that I think is always worthwhile to bear in mind for any studies in this domain of sort of extended release medications or anything that takes it out of the patient's hands.
Thank you. I appreciate it. And then before we get to you, Dr. Wandling, I saw one of the contractor medical directors, Dr. Miguel Brito of Palmetto, raise his hand. So go ahead, Dr. Brito.
Hi, Patrick, Dr. Mann. Can you hear me okay?
Yes, we can hear you well.
Great. Thank you. As a glaucoma patient, I'd like to ask, what is the efficacy of these kind of implantable devices when you realize that glaucoma is not a 2 to 3 year disease? It is, I've been a glaucoma patient for 15 years as a Hispanic male. So what evidence do we have that these implants are going to impact glaucoma long-term when we realize it's not a short-term disease?
And we can start with you, Dr. Wandling, since you had your hand up, and then we'll move to Dr. Cothran.
It's just, I think the word armamentarium was used earlier, or like arrows in a quiver, and it's, as things develop, we are continuing to use whatever is best available to us with the fewest side effects and fewest risk, right? And so every patient is, and we've discussed this before, is individualized. And so yes, this treatment may not be the best treatment for some people, but for some people, this may be the only option at this juncture, or this may be the best option at this juncture. And so that's why we're doing things like an iStent and it lasts for X amount of time, or in one of these intracranial implants that last for X amount of time. And, we may have to go back and do other interventions in 3 or 5 or 10 years. And that's just the frustration of glaucoma, because it's a lifetime disease that continues to get worse with time. And then just one other quick thing I wanted to mention was there's a Samuelson paper from 2021 that's really something that I like to go back to when I talk with patients about this or other colleagues. And it was a quality of life study based upon the iStent pivotal study, where they looked at VFQ-25 and the ability to get patients off their drops was really beneficial for people's overall happiness and things like that. And so this I think is an extension of that same idea. Thank you.
Thank you. Dr. Cothran?
Thank you. I think about, a patient that has glaucoma as being on a glaucoma journey. And as doctors, we're now in the driver's seat of that journey with the patient in the passenger seat. I think glaucoma surgeons, anterior seg surgeons, deserve every single possible tool to have within the armamentarium, that toolbox, that quiver, so that we can position these devices at the right point in time along the patient's glaucoma journey. It's one of the reasons that as a non-surgeon, I look out and I have some concern that I have expressed to colleagues about stacking multiple MIGs at the same time. And the reason is because once you have a failure, then if a particular MIG is only covered once in a person's lifetime, that patient no longer has that available. And so I think understanding what we have in the toolbox, both as optometrists and ophthalmologists, and allowing the surgeon the ability to choose the right device at the right time of that patient's glaucoma journey does allow us to protect that retinal nerve fiber layer, so that the patient has, a robust visual system of, nerve fibers that conduct in the visual system until the time that when the angels come. So, our job is to be very good stewards of the tools that we have and to use them very thoughtfully to care for our communities.
Thank you. Is there anyone else that would like to say anything else or respond to Dr. Brito's question? Dr. Liepin.
Yeah, Dr. Brito, I appreciate you're bringing a personal kind of experience to this question. I think you're absolutely right. Glaucoma is depending on when we diagnose it. Today in clinic I diagnosed a 45-year-old, and so we're talking a game of decades. And I tell my patients I hope that they live to 120, and I hope that that we're treating their glaucoma through then, and that they still retain good vision. So I think there's nothing in our we use the word armamentarium a lot. There's nothing in our armamentarium that lasts the entire life cycle of the disease. Even if you look to the, the quote unquote, the gold standards of, like trabeculectomy surgery, and, even a trabeculectomy is not expected to last a patient's whole life. We quote patients, look, if it lasts you for a decade, that's an amazing trab. So I always think of, I think a lot about real estate as a glaucoma surgeon, and anytime I can preserve real estate, whether that's physical in terms of the, not having to perform an incisional surgery that uses conjunctival space and causes scarring, or whether that involves not using up another medicine class, or basically anything I can do to move the ball, down the field, buy ourselves more time with functional vision, is a success. I think certainly the questions of value and getting the most amount of time for our input are important to think about from a health system perspective. But when I get excited by the prospect of devices or of interventions that provide me a new opportunity to buy ideally years of adequate pressure control before moving on to something else in the armamentarium. So that's how I sort of think about, how does a device with, maybe 3 years of pressure lowering fit into a 30-year journey? It buys us, another 3 years. And, I think we've discussed the reimplantations. We'll see what the data says in terms of exactly how long this can buy us. But that is how I sort of see it figuring into that larger picture.
Thank you. And if you can do it in 30 seconds, I'll give you the last word, Dr. Emmerich, before closing it out.
Oh, thank you. Thank you all for your interest in this topic. Appreciate this chance to discuss it. So as was mentioned, I think these are the first two intraocular implants that we can deliver drug into the eye where it is needed. Drops are really not a good way to get medication into the eye. I think a lot of people with early to moderate glaucoma, the worst part of their condition is the drops, not just the cost and inconvenience, really the life-altering side effects, dryness, irritation, stinging, burning. There's permanent changes to the eyelids that really affect quality of life later on. So anything that we can do to reduce drop burden, I think is really going to benefit our patients.
Thank you. And I wanted to thank you, all of you, for your time and volunteering to come on today to discuss these topics. We're grateful for the substantial effort you devoted to reviewing the evidence and for your thoughtful contributions today. And we appreciate everyone's participation. And with that, we conclude this meeting.